Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare. Join Baptist Health experts as they offer practical advice for clinicians covering a wide range of specialties. Cancer, neuroscience, orthopedics, and cardiovascular care are just some of the timely discussions you'll find right here on the Doc to Doc podcast.
Welcome to another podcast in the series from Miami Neuroscience Institute. And I'm your host, Michael McDermott, the Chief Medical Officer for Miami Neuroscience Institute and Chair of the Division of Neurosurgery at Baptist Health, South Florida. Today, I'm delighted to be able to interview one of my younger neurosurgery colleagues from Sunnybrook Hospital in Toronto, Canada, Dr. Nir Lipsman, Associate Professor in the Department of Neurosurgery at the University of Toronto. Now, this is a little bit of a hometown event for me because I myself was born and raised in Toronto, Canada, and it was not until after my internship that I moved west to Vancouver to complete my neurosurgical training. Those of you out there listening should not be surprised that a physician scientist from, quote, the Great White North, quote, would be one of the world's leading clinical investigators in the use of low-intensity focused ultrasound, but that is who Dr. Nir Lipsman is, a pioneer. Dr. Lipsman, can you tell us how you became interested in using low-intensity focused ultrasound and some of the difficulties you might have run into early in your clinical investigative career?
Absolutely, and thanks very much for the kind introduction. Always a pleasure to chat and to join. So I'm a neurosurgeon, as you well know. So as many of us, we got into neurosurgery to operate on the brain and to have access to the brain to treat the various pathologies that can affect patients. And I did my residency at the University of Toronto, and as is common at U of T, which is where I trained, I did a PhD during my residency. Where the focus was really on new technologies and how we can intervene in the brain in different ways. And that's really where I started to learn about focused ultrasound. And at that time, it hadn't been used yet in human patients for any human indications, or it was just beginning really to be used. And through a combination of factors, the University of Toronto really became a sort of an epicenter for a lot of this technology, and a major component was that one of the inventors was actually at U of T at that time. He still is, Kalervo Hinnanen. So that's when I first learned about the technology, the idea that you can use sound waves non-invasively through the skull and direct them onto discrete parts of the brain and generate a lesion in that part of the brain. So we've been doing that, obviously, in neurosurgery for many, many years, but now you can do it less invasively or non-invasively through the skull. So it was a really big shift in our thinking and using this technology, and we needed an indication. We needed the first trial to show that, in fact, this was safe and helpful and useful for patients. And the first indication was essential tremor. So essential tremor, common movement disorder, typically treated with surgery in those patients that don't respond to medicine. But with focused ultrasound, you have the opportunity to do the same procedure that you usually do in patients, but without having to open their head. So this for us was like science fiction, Star Trek talk, because we're used to opening the head and making skin incisions and holes in the skull, et cetera. But in fact, we did that in the first few patients, and it turned out quite well. And we expanded the work, and we built a focused ultrasound program around this, and now it's quite a common treatment. We're becoming a much more common treatment around the world.
Nir, for the audience, can you tell them about the two different spectra of focused ultrasound and the different conditions that each of those spectra are designed to treat?
Absolutely. So first thing I'll say is that, we're all used to, we have all heard of ultrasound, of course. It's sound waves that are at frequencies much higher than the human ear can hear. And we use ultrasound all the time in medicine. We use it to look at things, babies in the abdomen, and we also use it in neurosurgery. We use it to look at arteries in the neck, et cetera. When we talk about focused ultrasound, we're talking about the most common uses right now are two different ways of using ultrasound. The first is called HIFU, high frequency ultrasound. So here you're using ultrasound waves in the same way that if you were to take a magnifying glass and take all the different sources of light from the sun and focus it onto a discrete point and burn a hole in a leaf or something, that you're using the same thing, but instead of the sun's light, you're using sound waves. So you're harnessing the power of many different ultrasound sources onto a discrete point in the brain, and you're raising the temperature. You're causing a hole, a permanent hole in that part of the brain. And that's very useful to treat diseases where a hole will be helpful. Things like tremor, things like some of the troubling symptoms of Parkinson's disease, and increasingly some of the mood and anxiety that can accompany major depression and OCD. So that's HIFU, high frequency ultrasound. The other way you can use ultrasound is called LOFU, low frequency ultrasound. And there you're using ultrasound in a very different way. You're not generating a hole. You're not making a permanent lesion or hole in the brain. There, what you're doing is you're using sound waves to temporarily open the blood-brain barrier. So the blood-brain barrier is a physical barrier. It's like you can think of it like a saran wrap that wraps the very fine blood vessels of the brain. And the problem with the barrier, the blood-brain barrier, that's there in everybody, in all humans, is that it prevents things from gaining access to the brain that ordinarily you would want in the brain. Okay, so promising therapies or chemotherapies or growth factors or antibodies. Now, obviously, the barrier serves a function. It keeps dangerous things from entering the brain, but it also prevents these potentially useful therapies from getting in. So a way to overcome that has been a major goal for the last several decades. And that's what LOFU, low frequency ultrasound, allows us to do. It gives us a temporary window in very precise fashion to parts of the brain that we want to gain access to with these therapies.
For our audience down here in the States, we refer to the two different spectra as HIFU, high intensity focused ultrasound, and LIFU, low intensity focused ultrasound. And Dr. Lipsman mentioned LOFU, but LIFU, LOFU, same technology. Now, Nir, when you published some of your first clinical investigations in humans, you picked some conditions which I was surprised with. Like you picked a patient with ALS and used low intensity focused ultrasound to treat the primary motor cortex. Can you talk about what the rationale was for that, or was that just proof of principle of temporary disruption without difficulties?
Yeah, the second part. It was a proof of concept paper. So as you know, ALS is extremely challenging disease. It's a disease where there are no effective treatments. It's one of the toughest diseases we have in medicine. It's not for lack of trying that the field has not yet developed effective therapies. There are tons of efforts around the world geared towards how can we slow down the disease? How can we even potentially reverse it? With focused ultrasound, what we have is the opportunity to potentially enhance the delivery of some kind of therapy to the brain that may be effective. But as a first step, you first need to show that you can, in fact, open the blood-brain barrier in patients with ALS. So that is a critical first shot across the bow, if you will. So we needed to show that, in fact, in these patients who are affected by this disease early on in their disease, but nevertheless, they're affected, that we can target a really important part of the brain, which is the motor cortex. So it's a part of the brain that controls motor function for the other side of our body. The right and left, of course, are crossed in the brain. So we needed to show that, in fact, this part of the brain that is primarily affected in ALS can be safely opened, that it's not associated with bleeding in the brain, with any strokes, with any swelling, or anything dangerous. That's a first step. And that's, in fact, what we wanted to show, and that's what we showed. And the other interesting thing that we did is we used something called an fMRI in this study. So an fMRI is a special sequence of everybody's heard of an MRI of their brain, of course, but an fMRI allows you to see in real time activity of the brain. So while the patient, for example, is moving their right arm, we can see which part of the left side of their motor cortex lights up. So it shows us exactly where in the brain we could target with focused ultrasound. And that's exactly what we did. We wanted to target a specific region of the motor cortex to demonstrate how specific focused ultrasound really can be. And that's what we were able to show. So it looks like it was safe, well tolerated. And now we're developing a trial where we're going to deliver something to the brain, a potentially useful therapeutic.
Mm-hmm. Nir, in the United States, the Federal Drug Administration is a executive body which reviews applications for new drugs, new treatments, and they're extremely conservative. And I would say it's very tough to get new procedures and drugs through, much tougher than it is up in Canada, for example, with drugs. But what about the difficulties that you may have encountered with in the Canadian healthcare system with getting a clinical trial going? Can you talk a little bit about that process?
Yeah, absolutely. I mean, it's something that we, I would say, commiserate on. Many of us in the field who do this kind of work. There's no question that the checks and balances are important. They're critical that they're in place. Everybody's motivated by the same thing. We want to develop treatments that are safe for patients and obviously effective for patients. And we need to primarily focus on safety. But for anybody that does clinical trials, especially early phase clinical trials, where it's the first time you're doing something in a human patient or very early on in the development of a certain technology, that 80 to 90% of the work is going to be regulatory. It's going to be dealing with your research ethics board. It's going to be dealing with your like a clinical trial research organization, CROs. It's going to be dealing with the FDA in the US, Health Canada in Canada, and the different provincial and federal authorities that ultimately give us the go-ahead to do something. So for us, the very first trials that we did with LIFU or LOFU or low frequency ultrasound took a very long time to get approved. So it took upwards of a year, if not more, to go through that process. We are currently doing a trial where we're delivering chemotherapy to children with a brainstem tumor, in their brainstem, very malignant tumor. Where, as you know, it's uniformly fatal, within about a year of diagnosis. It took us 2 years, if not more, slightly more, to get that study approved in Canada for a disease for which, again, there is no effective treatment. So some patients passed away waiting for that trial to get approved. And ALS is very, very similar, where the average illness duration is on the order of just a few years. So we don't want patients waiting. We don't want patients dying to enroll in trials. Ideally, there would be some kind of sort of parallel pathway where potentially transformative technologies can be trialed, again, in a very safe, judicious, empirically, scientifically responsible way, but nevertheless streamlined so that we can get these technologies to patients and at least study them as quickly as possible. So it's been challenging. Now, I will say that the more you do, the more you familiarize yourself with the process, the more the people know you at these different organizations, and that's very helpful. So fostering those relationships with industry, with your research ethics board, and with others is key.
Yeah. So talking about federal and state provincial approvals for the use of a device. High-intensity focused ultrasound was approved for essential tremor in September 2022 here in the U.S. And then a short time after that, I believe 8 months later, a tremor associated with Parkinson's disease was also an approved indication. And there's a number at Baptist here, for example, we've done over 125 high-intensity focused ultrasound for essential tremor. And you might be interested to know we're going to be reviewing the lesions created on the 3-month follow-up scans, comparing that volume and position of the centroid with the planned volume and planned centroid on the MR stereotactic images, as well as the clinical outcome. But as you know, there are many centers in Europe where they've already reviewed longer-term data up to 4 years, and the results appear to be durable. But, the devices are very expensive. The low intensity focus ultrasound transducer is $1 million. The high intensity focus ultrasound machine transducer is $1 million. But in spite of that, there's been a number of sites opened up in the state of Florida, which are part of a research consortium. But I was wondering, what's the availability of that technology up in Canada? You have one in Toronto, but what about elsewhere in the country?
Yeah. We have two actually in the greater Toronto area. So there's one where I work at Sunnybrook. There's another one in a hospital in downtown Toronto, Toronto Western Hospital. There are machines in Quebec, and we believe there will be another program, and also in Calgary, and there may be another program coming online, eventually in Vancouver. So yeah, it's a growth in, it's a growing field, and we're finding that our referrals are growing about 20%, 25% per year. It's critical to have a movement disorder program partner with whom you can work to assess patients, follow them in the long run. We found that the uptake has been significant, as you know. So let me ask you, what is DBS performed very commonly at your hospital?
Yeah, so we do about one case a week or one every other week. And so I think the high intensity focus ultrasound has replaced DBS for essential tremor, but we still use it for Parkinson's disease, obviously, for the bradykinesia portion of the disease that you cannot treat yet. As far as we know, we can't treat that with other methods. So
same here. And I think a few patterns have emerged. One is when patients find out that there's a less invasive option, oftentimes they want it. Number one. Number two, a lot of our referrals are driven by patients. And it's the patient that is in the community that has a tremor that goes to their primary care doctor or their neurologist and says, I want to be referred to Center X to be evaluated for ultrasound. So this has been a grassroots sort of growth that has happened. We recently passed, I think, our 400th patient, or 400, or between 4 and 450, and there are some centers in the U.S. that have, are on par with that, and there's no question you guys are the trajectory is increasing, and I think what's happening is the referral threshold has been lowered with the availability of focused ultrasound. So it's not the same population that was previously being evaluated for something like DBS. I think the population is actually larger. We are also finding a bit of a indication creep, and I don't mean that in a negative way. I mean that, in the past, we were operating on patients with, severe disability, can't feed themselves, can't wash themselves, or really look after themselves. And now there are patients that, they still have refractory resistant essential tremor, but it's more instrumental. They can't write anymore, or they can't hold a coffee cup with one hand. They have to use two hands. So we're finding that, the severity that we're operating on is probably decreasing a little bit over time. So that's something we're definitely seeing as well. So I anticipate that it probably will continue to grow. There's also a movement in neurosurgery, as you well know. I wonder if you see it also in neuro-oncology, where the move towards less invasive, I see it as a kind of one-way street. We see it in spine, we see it in vascular, we see it in functional. You tell me, do we see it in neuro-oncology? I suspect so. There's a push towards, smaller incisions, smaller operations, more ambulatory work, and things like that.
Yeah, I think what I would like to see in neuro-oncology is approval to use, potentially promising therapies that are new, as you mentioned, for a almost uniformly lethal disease, rather than and allowing us to use that up front rather than waiting until the third or fifth recurrence. When it's really an impossible situation. But I don't do the functional neurosurgery, but tell the listeners about the pre-test that you do with HIFU for essential tremor, and then how you affect the lesion and the immediate result that the patients get.
Yeah, I mean, it never gets old. It's a privilege to be a part of that process. So generally speaking, about 2/3 to 3/4 of patients with essential tremor respond well to medications. And there are effective pills for medications, beta blockers and others. But about 1/4 of patients, or up to 1/3, don't, or they don't tolerate the meds, and they're surgical candidates. So they would see a surgeon. But as a first step, they would need to see an expert in movement disorders, somebody that can make the diagnosis, can offer them treatment, and really make the assessment and say, yes, you've reached the limit of what we can offer you medically. I'm going to refer you to a surgeon. So that process takes time, but necessary, because obviously any surgical intervention, even less invasive ones, are going to have some risk, which obviously we can discuss. Once they're referred to a surgeon and they see me, we go over all the options, DBS, focused ultrasound, and all else. And if we decide with focused ultrasound, they'll undergo an MRI, they'll undergo a CT, and a CT is important because we need to look at the skull. The skull matters a lot for focused ultrasound, HIFU for HIFU. They'll have a baseline assessment of their tremor. They'll see our neuropsychologist. They'll see our speech language pathologist, et cetera. We still study, even though we've treated hundreds, we still want to study all of our patients and make sure that they're optimized, and that we optimize the procedure. And then the patient is scheduled for treatment. On treatment day, they come into the hospital. We attach a frame to their head. It's all frame-based procedure. We do a haircut. We shave the head down to the scalp for these procedures. And then the whole procedure takes about, I would say, 2 hours or so in the MRI scanner. The first half approximately just planning sequences, and then we actually do the treatment. There's usually an anesthesiologist present, making patients feel comfortable during the procedure if needed, but the whole thing is done with patients awake. It's useful, obviously, to do it awake because we can essentially map where we are in the brain. And before we make the permanent lesion in the brain, we do a test lesion. We heat the tissue to a point where it doesn't quite die. The neurons don't quite die, but they are knocked out, if you will, temporarily. So we can see if there is an effect on the tremor or if there are any side effects, if there is any numbness or tingling, and then we make adjustments based on what the feedback the patients give us. Once we're happy, we turn the power up, we make a permanent lesion, and then the procedure is done. They come out, and if it's effective, the tremor is gone. Yeah. And they're able to drink right away. They're able to essentially go home within about 2 hours of the procedure.
Yeah, very good. Yeah, it's pretty remarkable when you see it in person. I'm going to go off script a little bit here because something has happened in the publication world since we put this together, and comments about the 3-patient series published in New England Journal of Medicine, not powered to evaluate neuropsychological outcome, but I think really just for toxicity. I know that our group here was shocked to see a publication with 3 patients and a editorial for the same article. Brought a lot of attention to the problem of Alzheimer's and the potential for using low intensity focused ultrasound. And obviously we got a tidal wave coming potentially for this disorder. Yeah. So I just want to know your thoughts about that. Yeah. Staying apolitical.
Yeah. I mean, I think Alzheimer's, it's hard to talk about Alzheimer's, which is obviously a political minefield. I mean, people have staked a lot in different camps in the Alzheimer's field. You have the amyloid school, the tau school, you have the antibody crowd, the anti-inflammatory crowd, the vascular crowd. So it's a politically loaded field already. And then once you factor in a device, a device where you're opening up the blood-brain barrier, it just makes a touchy subject much more controversial, which may account for why it was published in the New England Journal. The data, albeit small, was compelling. It showed that on the side that was treated, they were able to clear amyloid in significant amounts in large volumes. It is, very much early. I would preface the analysis with saying it's definitely early days. Certainly for those in the field, as the blood vessels in the brains of patients with Alzheimer's disease are exquisitely fragile. I mean, they're laden with amyloid. Amyloid is the leading cause of brain hemorrhage in the brain, spontaneous hemorrhage. So opening up the blood-brain barrier is fraught with some at least theoretical risk. So the fact that one can do it safely is a major thing, and we've published that as well before this paper. But I think it shows you sort of the status of the field and where we're at, that there's such a drive and thirst for any kind of movement and development that even small early phase trials, can be, on the cover of the New York Times. So I think, it's critical to put all this stuff in context. It's promising, but it needs to be reproduced. Of note, as you know, the drug that they were using, aducanumab, is now out of production. Is now not going to be used anymore. So really, that's how fast the field is changing. That you can have a trial, you can publish it in a New England Journal, and then the drug that you were using is now discontinued. That's the speed of science, but also the speed of the technology. But it's as you said, it's good for the field. I think it's good exposure. I think it shows that ultrasound has some legs, and we have to investigate it further.
Yeah. So one last question: if you were to put on your thinking cap and imagine the future and the year 2035, how do you see focused ultrasound being used beyond the current indications?
Yeah, it's a great question. The way that I think about this often is, if you're going to design a device or any tool really, and you want it to be truly disruptive and change the way in medicine, and change the way that things are done in medicine, I think you want it to do one of three things. You want it to be excellent at diagnosis, potentially. You want it to be excellent at treatment, and maybe even a third thing, which is preventing the disease from occurring or progressing, et cetera. There are very few devices, in my view, currently, that have at least the potential or promise to do all three, like focused ultrasound. So if I were to look at the next couple decades in each of those categories, I would say I'm optimistic that we'll be able to use ultrasound as a diagnostic tool, as a liquid biopsy tool in the next couple of decades, not only for brain cancer to help us identify diagnosis, but also monitor treatment over time, but also in the neurodegenerative diseases, to be able to pick up early together with the liquid-based biomarkers. You can imagine somebody going, for a regular MRI scan and having a non-invasive liquid biopsy of the brain to see if they're developing certain hallmarks of certain diseases. So I think that will come online in the next few years. On the treatment side, I think we're going to see rapid advances in our ability to deliver important therapeutics to the brain. So it's going to be chemotherapy, and it's going to be also things like growth factors, enzyme replacement therapy, other immunotherapeutic approaches. What's nice about ultrasound is that it's agnostic to what you're delivering with live through. So you can have rapid advances in the biological world that now you can superimpose on your technical advances with ultrasound. So we're going to see we're going to see the birth of a new discipline, which is, I think, ultrasound medicine, where you're delivering therapeutics to the brain guided by ultrasound. And lastly, I think we're ultimately going to see preventative strategies like gene therapy, and like other approaches like neuroprotective strategies to protect the brain after a stroke, or to protect the brain after a traumatic brain injury. You can imagine a situation where somebody, gets a clot-busting agent, and then they get, as part of their CT or MRI, or even in the ICU, they get focused ultrasound to try to protect the brain that is not yet gone by releasing growth factors or other protective agents that are on board. So, and we're starting to see that already in preclinical models. So I think that we're going to see in the next couple of decades diagnostic, therapeutic, and preventative strategies.
Well, Dr. Lipsman, thank you for taking the time today to speak to us about high and low intensity focused ultrasound technology. And I'd like to congratulate you on your pioneering work and early successes. Well, ladies and gentlemen, that will end this podcast on the topic. And I'd like to thank you for your time and attention today.
Thanks very much.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.